Let's jump right into this explainer, because we are unpacking a really fascinating and honestly absolutely critical topic today. We're going to be looking at exactly how cardiovascular disease, or CVD, became the undisputed heavyweight champion of global mortality. We're talking the leading cause of death across the entire globe. We're going to trace the history, dig into the data, and really try to understand the massive shifts in human behavior and demographics that brought us to this exact moment in global health.
Right out of the gate, we have to talk about this number, 19 million. Just let that sink in for a second. In the year 2022, over 19 million deaths worldwide were caused by cardiovascular disease alone. It's a staggering, almost incomprehensible figure. To put that into perspective, it means that roughly 1 out of every 3 deaths on the planet is tied to the heart and blood vessels.
And this naturally leads us to a pretty incredible question. Before the 1900s, CVD caused less than 10% of all deaths. So how on earth did humanity shift from constantly battling infectious diseases, which totally dominated our survival for millennia, to facing this massive chronic cardiovascular epidemic?
All right, Section 1, the global CVD burden. Let's start by getting a handle on the sheer scale of the problem right now.
When you break down the numbers, CVD is responsible for nearly 33% of all global deaths. It completely overshadows everything else, other non-communicable diseases, communicable diseases, injuries, you name it. But here is the kicker, and it's a crucial point we're going to keep coming back to. The vast majority of this burden, we're talking well over 80%, is heavily concentrated in low and middle income countries. It is not just a wealthy nation problem anymore.
Moving on to Part 2, the epidemiologic transition. To really understand how we got here, we need to look at a framework driven by the forces of industrialization and urbanization. Think of this transition like a historical roadmap of human health across 4 initial stages. We start in Stage 1, pestilence and famine. This was pre-1900, where infections and malnutrition ruled. Then, as public health improved, we hit Stage 2, receding pandemics. Infant mortality dropped, people lived a bit longer, and we started seeing more hypertensive issues. But Stage 3 is where things really shift. It's the degenerative or man-made era. We started eating more calories and moving a whole lot less. And suddenly, CVD death rates soared up to 65% of all deaths, mostly from coronary heart disease and strokes. Finally, in Stage 4, the delayed degenerative phase, our medical treatments got better. We started pushing these cardiovascular events to an older demographic, bringing the mortality rate down slightly. It's kind of a paradox, right? All our improvements in public health actually paved the way for chronic cardiovascular issues to take over.
But here is where things get genuinely alarming. We are now seeing the emergence of a 5th stage. Experts are calling it the age of inactivity and obesity. Because physical activity continues to plummet and caloric intake keeps rising, we're seeing an explosion in overweight populations, diabetes, and hypertension. And it's happening even in kids. Because of this, those mortality rates that had been steadily falling during Stage 4, they are actually starting to climb again in some regions. It's a really sobering reversal of our progress.
Section 3, high-income versus low- and middle-income countries, or HICs and LMICs for short. Let's zoom in on how this transition is playing out completely differently depending on a country's wealth. If you track CVD death rates from 1990 to 2019, you see this massive, stark divergence. High-income countries saw a steep 50 to 60% decline in their age-standardized death rates, but when you look at lower and middle-income regions, the trend is way flatter and significantly higher. Basically, the incredible benefits of Stage 4, those advanced, delayed degenerative treatments, they simply haven't reached everyone equally. So, why the huge gap? Well, on one side, you have high-income countries. They are managing an older, shrinking proportion of the global population. Their decline in CVD rates is definitely slowing down, but they generally have the medical infrastructure to manage it. On the flip side, you have low- and middle-income countries, which happen to house 85% of the world's population. They are dealing with explosive, rapid urbanization. Their populations are growing and aging much faster than their mortality rates are dropping, which means the absolute total number of CVD deaths in these regions is actually going up, and they're carrying a particularly heavy burden when it comes to strokes. Let's put a human face on this with a quick clinical scenario. Imagine a fast-growing urban center somewhere in South Asia or Latin America. Just 1 generation ago, a typical patient in this community was mostly facing the threats of malnutrition and infectious disease. But today, because of incredibly rapid shifts in diet and work environments, that same patient is walking into a clinic presenting with hypertension, obesity, and early-onset coronary heart disease. The local healthcare infrastructure, which was originally built to fight infections, is just suddenly getting overwhelmed by these chronic, man-made conditions. Which brings us to Part 4,
Major CVD risk factors. What are the specific biological and behavioral villains actually driving this clinical shift?
We are really looking at 6 major conventional risk factors here: smoking, high blood pressure, abnormal cholesterol, obesity, type 2 diabetes, and just plain physical inactivity. These are the primary culprits globally. And the most important thing to grasp here is that these are largely behavioral and modifiable. The data shows that regional variations in death rates correlate almost perfectly with these exact behaviors. Whether it's the global spike in diabetes or the fact that we're moving less than ever, these 6 factors are the actual engine driving the epidemiologic transition.
I want to zero in on one specific massive threat: tobacco use. We've got over 1.3 billion users worldwide, and it is directly causing 3.2 million CVD-related deaths every single year. And while overall global smoking rates are declining, there's a crazy inequality here too. High-income populations still smoke at nearly double the rate of low-income countries, but because of population growth, the total number of smokers worldwide is still expected to rise. Millions of cardiovascular deaths, and it's completely preventable. All right, part 5, strategies for global prevention. We know the problem, so let's move to the solutions. How does public health actually combat this?
The roadmap to fixing this requires 3 distinct overlapping strategies. Step 1, population-wide measures. We're talking big national anti-smoking campaigns and redesigning cities to actually encourage walking. Step 2 requires targeting high-risk subgroups with proactive screening and low-cost prevention for things like blood pressure and cholesterol. And finally, step 3 is the necessary allocation of resources to acute care and secondary prevention, basically helping the people who already have the disease to survive and thrive. And when it comes to that second step, low-cost prevention, we've got a real game changer, the poly pill. It's exactly what it sounds like. It's a highly effective, incredibly low-cost intervention that combines aspirin, a statin, and blood pressure medication into just one single daily dose. It's proven so effective that it was literally added to the World Health Organization's essential medicines list. This is the exact kind of scalable, accessible tool that allows lower-resource countries to manage high-risk patients efficiently without completely bankrupting their healthcare systems.
As we wrap up this explainer, I want to leave you with a thought to really chew on. We just traced our journey from an agrarian past to our highly sedentary, urbanized present. So look at the world right outside your door. How is the environment around you? The availability of fresh food, the presence of walkable streets, local smoking policies. How is all of that shaping your own heart health today? The global data makes one thing crystal clear. Our cardiovascular destiny is largely designed by how we live. Thanks for hanging out with me for this explainer. Keep learning and keep asking great questions.